Hello, everyone. Welcome to UNC Core Center for Clinical Research Speaker Series for May 27th, 2020. We appreciate you joining us for today's talk. Our presenter today is Dr. Jennifer Leeman, an Associate Professor in UNC School of Nursing. Her presentation today is titled An Introduction to Implementation Science, Speeding the Translation of Effective Interventions to Wide-Scale Practice. Dr. Leeman, whenever you're ready to begin, please feel free.
All right. Good morning. Today I'm going to start with a brief introduction to implementation science and then provide two illustrations from my own research. The first on implementing a systems intervention and the second a behavior change intervention. So starting with the introduction to implementation science. Why implementation science? We've developed a lot of effective interventions that could improve patient and population health, but only a small number of those interventions have been translated to wide-scale practice, and often they're translated in ways that don't achieve the same level of effectiveness as in the research study. So you can have a highly effective intervention, but it won't improve population health unless it reaches the intended patients and populations, is adopted by providers and practice settings, is implemented with fidelity, and maintained over time. In other words, interventions need to achieve good implementation outcomes in addition to good effectiveness outcomes. And each of those bolded words is an implementation outcome from the RE-AIM framework, which I'm going to touch on a little bit more shortly. So this is the conceptual framework that's going to guide my presentation today. It's adapted from a framework developed by Enola Proctor and colleagues. And when council posts the video from this presentation, she will also post a list of the references that I'm going to make as I go through the presentation. So to the left, we have what is implemented, and that's an evidence-based intervention. And I define this very broadly to include practice guidelines, products, packaged intervention programs, policies, anything that's been tested and found to be effective at improving health-related outcomes over one or more well-designed research studies. Our goal in designing these interventions is to achieve strong effectiveness outcomes. So that's all the way at the other side of this framework, are your effectiveness outcomes. And we want to achieve those across multiple practice settings. There are many challenges to translating our evidence-based interventions into broad-scale practice so that they achieve the same effectiveness outcomes or similar outcomes as in our research studies. And that's the focus of implementation science. Implementation science is about understanding the barriers to moving an evidence-based intervention into wide-scale practice. And so you see that with the multi-level contextual factors. We want to understand what those are. It's also about selecting implementation strategies that can help us overcome barriers and so that we can achieve strong implementation outcomes. So I'm now going to do a deeper dive on each of these central components of implementation research, starting with multi-level contextual factors. So this is the Consolidated Framework for Implementation Research, or CFIR. And this is the graphic that Dan Schroeder and her colleagues created to depict this framework. Text in the individuals who will adopt and implement an intervention in practice. Those individuals work within a practice setting, which she refers to as inner setting. And that inner setting exists within a wider socio-political context and community or outer setting. To the left of this framework, you can see the intervention. The intervention on the left does not fit well with the multi-level context. On the right, you see a much better fit, and that's one of the central goals of implementation science, is to integrate our interventions so that they fit well within the practice context. And at the bottom, you see processes, which are the processes that are used to achieve that good fit. So this is just another depiction of the Consolidated Framework for Implementation Research, and it shows the 5 domains or levels. And the CFIR has, I believe it's 39 constructs that fall within each of these 5 levels or domains. And here I just put a few of them to give you a flavor for each of them. So interventions, the complexity, cost, and strength of evidence and support of an intervention all influence how readily it will translate or be implemented into practice. Characteristics at the level of the outer setting include patient needs and resources, external policy and incentives. The inner setting includes things like leadership engagement, available resources at the individual level, and in the CFIR, this largely refers to individual providers and staff. It includes their knowledge, beliefs, and self-efficacy. And implementation processes include things like planning, engaging, reflecting, and evaluation. And I've included here also a website where you can get a great deal more information about the CFIR. So understanding these multi-level contextual factors is key to adapting interventions so that they fit, to selecting implementation strategies that will overcome barriers and leverage facilitators within the multi-level context, and to evaluating when and why implementation is or is not successful. So the second component of implementation research is implementation strategies, which are how we achieve good implementation outcomes. And this is a definition from Proctor and colleagues. Implementation strategies are methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program or practice. And so here is a list with some examples of implementation strategies. These examples are drawn from a taxonomy of implementation strategies that was created by Byron Powell and his colleagues, and includes, I believe, 73 different strategies, such as audit and feedback, practice facilitation, which is also sometimes called QI coaching, educational meetings, changes to the electronic health record, reminders, leadership engagement, etc. I'm also very interested in the overlap between implementation strategies and quality improvement tools and methods. Overlap, and how can we better integrate those two things. And so also, as you're thinking about implementation strategies, think about what you might pull from quality improvement, such as QI teams, process mapping, root cause analysis, and plan, do, study, act cycles, or small cyclical tests of a change to implementation, PDSA cycles. So the goal with implementation strategies is, once you understand your multi-level contextual factors, select and tailor your implementation strategies to target those contextual factors. So think about what barriers you are trying to overcome and how your implementation strategies can help you overcome those barriers, and what strengths and resources are available within the multi-level context that you might potentially use your implementation strategies to leverage. So the third core component of implementation research is implementation outcomes. And we've already talked about the REAIM framework. I provide a link to the REAIM framework at the bottom. These are metrics that you can use to assess the extent to which you are reaching the intended patients and population, particularly those at greatest risk, achieving high levels of adoptions by both providers and practice settings, and the extent to which the intervention is being implemented with fidelity, in other words, as designed, and maintained over time. There's another widely used framework for implementation outcomes, and that's, again, Proctor. And so her taxonomy builds on the REAIM framework and adds additional implementation outcomes, such as assessing whether or not the evidence-based intervention and its implementation are acceptable to providers and staff, are viewed as appropriate, and are viewed as feasible for use in practice. Also, measures of cost and additional outcomes. So now I'm going to provide you with 2 examples from my research. In both examples, I will talk through how we identified multi-level contextual factors that may impede or support implementation, how we selected implementation strategies to target those contextual factors, and then how we determined whether the implementation strategies had a positive impact on implementation outcomes. So the first is a systems intervention. This is the Connect Home Transitional Care Intervention, which was developed by my colleague, Mark Toles, at the School of Nursing. He started his work developing this intervention during his doctoral studies and currently has an R01 funded study to test its efficacy. He developed the intervention to address the problem that 1.6 million older adults in America transfer from hospitals for short stays in skilled nursing facilities where they receive rehab and other services prior to being discharged to home. Within 90 days of discharge to home, more than 50% of these older adults die, use emergency services, or are rehospitalized. His intervention seeks to improve these outcomes by increasing collaboration and communication among the multidisciplinary team that cares for older adults in the skilled nursing facility, and also with the older adult themselves and a family caregiver. And so the intervention involves 4 steps. The first step happens shortly after admission to the skilled nursing facility and involves each of the involved disciplines begins to work with the older adult and caregiver to set goals for continuing care at home. Then within 2 weeks at the latest, a care plan meeting is convened that involves all the disciplines plus the older adult and family member to begin developing a more formal plan of care for home. Then just prior to discharge, the staff trains the family caregiver and older adult on the care plan and also activates community support, which means that at the very least, an appointment is made with a community provider, and that community provider is provided with a current list of medications and with the plan of care. And then the final step is calling the older adult at home within 72 hours of discharge. So as Mark has been developing the evidence base for the effectiveness of this intervention, he started to think about, well, this is a huge need. How can I make sure that this gets moved rapidly into wide-scale practice? And so that's when we started partnering to address the question of what strategies are needed to implement Connect Home into wide-scale practice. And so Mark and I are currently doing our second small study, and I'm going to tell you about the first study. Both of them were done in partnership with Lutheran Services of America, which is a national nonprofit that works with skilled nursing facilities nationwide. And one recommendation I would make to anyone who's developing interventions that they hope to ultimately move into wide-scale practice is to start developing relationships with partners that can help you achieve that goal. And so in this case, the partner is Lutheran Services of America. Together with Lutheran Services of America, we identified 4 skilled nursing facilities in 4 states, Maryland, North Carolina, Michigan, and New Jersey. And with funding from the Weinberg Foundation, we did a 1-year trial of implementation strategies. So I'm going to tell you how we selected our Connect Home implementation strategies, and I want you to know there's a lot of different ways to do this. And so I'm just showing you a few examples with this study and the next, but there are other ways to do this. In this case, to identify the multi-level contextual factors, we did a retrospective review of the formative research and pilot studies that Toles and colleagues did to develop and test Connect Home. So this included a systematic review of the literature, observational study, and several pilot studies. We also talked to our practice partners, Lutheran Services of America, about what barriers and facilitators they saw and what strategies they thought would work well. So some of the contextual factors that we identified, and these are organized by the CFIR domains. At the intervention level, Connect Home is a complex intervention, and it is hard to implement complex interventions. At the outer setting level, reimbursement policy has changed over the past few years, creating incentives, financial incentives for skilled nursing facilities to reduce hospitalizations. And that is a driver for nursing homes to participate in this intervention. At the inner setting level, staff turnover is high and leadership support is critical. At the level of individual SNF providers, staff lack knowledge and confidence in their ability to prepare older adults and their caregivers for the transition home. And in terms of processes, skilled nursing facilities are required to have quality improvement programs. So the next step was working with Lutheran Services of America to talk about the strategies, to work on developing strategies that would address these multi-level contextual factors. So at the outer setting level, we did leverage the change to reimbursement policy as an incentive in our marketing efforts to engage skilled nursing facilities. Inner setting level, we made sure that leadership in this interested skilled nursing facilities understood what was involved in implementing this intervention, and we got them to sign a memorandum of understanding, or MOU, committing to providing the support that would be necessary for success. At the individual level, to increase staff knowledge and self-efficacy, we created a learning collaborative where we brought together representatives from each of the nursing homes for 2 full-day in-person meetings. We also provided trainings in the nursing homes so that we could reach a wider number of staff. And then we distributed educational materials. So these are the strategies we developed for Lutheran Services of America and ourselves to deliver together. In addition to that, we identified implementation strategies that we asked staff in the skilled nursing facility to do. So we asked, in order to address the complexity of the intervention, we asked the skilled nursing homes to designate a site champion who would cheer on and support and oversee implementation. We also asked the SNFs to embed the discharge planning template in their electronic health records. To address staff turnover, we asked them to develop policies and procedures for training staff that were hired after the in-person training that we did on site. And then we built on their existing QI programs by asking them to create a Connect Home quality improvement team, and for those teams to conduct small improvement cycles or Plan, Do, Study, Act PDSA cycles. And then we asked them to collect improvement data to monitor implementation over time. So this is essentially what our implementation strategies looked like. You see at the top the strategies that Lutheran Services delivered, and then below that are the strategies we asked the skilled nursing facilities to enact. So now I'm going to tell you how we evaluated the impact of those strategies on implementation outcomes. I would also note here to the right in the gray box that In his effectiveness studies, Mark is assessing effectiveness outcomes such as caregiver and patient report of how well they're prepared for discharge, and also rates of rehospitalization. In this study, we did not look at those effectiveness outcomes. We focused only on the implementation outcomes. So we measured reach, which is the number and percent of eligible patients who got Connect Home. We measured engagement, staff participation in the implementation strategies that were delivered by Lutheran Services of America. We measured implementation fidelity. Did staff complete the implementation strategies we asked them to complete per protocols? We measured intervention fidelity, whether or not staff delivered Connect Home per protocols. And then we looked at acceptability. How did staff perceive Connect Home? And I'm going to just review our findings for the middle three of those outcomes. So in terms of SNF staff engagement in Lutheran Services strategies, excellent attendance at the 2 learning collaborative meetings and at the on-site training. The monthly coaching phone calls were mixed, with 2 SNFs participating in the majority of calls and the other 2 not. Implementation fidelity, all the skilled nursing facilities had active site champions. They all made changes to their electronic health records. However, while they all created quality improvement teams, those teams did not meet regularly and they did not engage in plan, do, study, act cycles. In terms of intervention fidelity, this is a little hard to see, but I would note that this graph starts at 79%. So we had very good intervention fidelity. So over 80% of patients received each of the components of Connect Home that we monitored. So 88% got a transition plan of care, 82% had a care plan meeting by day 14, etc. So the question this raises is, if we got such strong intervention fidelity, why do we care that we didn't get good implementation fidelity? And the reality is that during this year, our team and Lutheran Services were actively engaged with these skilled nursing facilities. And so these are the outcomes, fidelity they were able to achieve while we were actively engaged. What very often happens is after that active engagement ends, the intervention slowly peters out over time. And it's very difficult to maintain an intervention in practice. And we believe that getting the quality improvement team engaged is critical to maintaining the intervention after we leave. The quality improvement team can continue to monitor how well the intervention is being implemented, and ideally would conduct PDSA cycles to improve implementation when it lagged. So in our current study, small study, we've made some changes. And so one of the changes is that first bullet there. We've asked QI teams to report on their monthly meetings. So we're holding them accountable and asking them to let us know that they met, who attended, and we've given them a structured reporting form for planning and conducting PDSA cycles. The third bullet there, we're also going to measure maintenance 1 year after study completion. So now on to my second intervention, the behavior change intervention. And we just finished 5 years of funding from the CDC and are beginning a second 5 years of funding related to the implementation of this behavior change intervention, it's an intervention that has had several iterations, was developed and has been developed by researchers at the Center for Health Promotion and Disease Prevention here at UNC, and is a healthy lifestyle intervention. In this study, the healthy lifestyle was focused on preventing cardiovascular disease by promoting healthy dietary intake, physical activity, medication adherence, and smoking cessation. And the format is 4 in-person one-to-one counseling sessions and 3 booster phone calls. I would say that the healthy diet and physical activity are fairly constant over iterations of this intervention. And sometimes it includes the medication adherence and smoking cessation, but not always. So the purpose of this study was to develop and test the strategies needed to implement the evidence-based heart-to-health intervention using a community health worker model. So this was an engaged partnership. And so we engaged with federally qualified health centers and health departments in 2 rural North Carolina counties. This is Hertford and Edgecombe County that you're seeing on the map, both of which have a majority African-American population, large numbers of people living below the poverty level, and of North Carolina's 100 counties, they rank 94th and 96th for health behaviors. So the study aims were first to conduct engaged formative research to design implementation strategies, to test strategy impact on implementation and effectiveness outcomes, and then to develop a dissemination plan. So aim 1 had 3 steps, and this is where we assessed contextual factors and selected our implementation strategies. And I'm going to go through each of these steps. I want to make the point again that there are many different ways to do this. In this case, we used an engaged partnership. We did not use the CFIR as a structured framework. Instead, we closely engaged with partners to understand the context and to collaboratively co-create implementation strategies that would align well with the realities of the context within each of these 2 counties. So the first step was we engaged practice and community stakeholders. That's a picture of me standing in front of a cotton field on the drive to Hertford County. For one of our monthly engaged planning team meetings. Our planning team included the individuals who were to supervise the CHWs and representatives from the federally qualified health center, the Department of Health, the cooperative extension, the community college, the local hospital, the wellness center, and ourselves. We conducted formative research to identify contextual factors. This included our monthly engaged planning teams. It also included interviews with stakeholders from community organizations, geographical information systems mapping of community resources, and interviews with community members. So this is a sampling of the contextual factors, some of the contextual factors that we identified, which would be common to any or very familiar to others who have done research in this part of the state. Lack of public transportation and long travel distances, low literacy and low incomes, limited access to healthy foods, few sidewalks or free places to be physically active, distrust of outsiders, distinct local food preferences, a positive history with community health workers, strong local collaborations, and the community had already gone through a process in which they had prioritized the health needs of African American men. So again, in designing our implementation strategies, we worked together to develop an approach that would align with the realities of the context. And so, for example, we created a position description for the community health worker. And in that position description, we determined that they should travel to the participant's home or to another location of the participant's choice as a way of overcoming the travel and transportation barriers. We created an inventory of the county's community and clinical resources and I'll talk about that a little bit more. And in developing that, our goal was, yes, this county has few resources, but it does have some resources. So let's make sure everyone is aware of the resources that are available and how to access them. We developed a Heart to Health participant manual, a workflow for how we would identify and recruit eligible patients and refer them, or community members, and refer them to the CHWs and link them to community resources. We developed a CHW training plan, and we developed tools and protocols for tracking participants' progress through the intervention. So the inventory of community resources, we identified 73 resources that would support healthy behavior changes. And for each of those resources, we identified the times that they were open, where they were located, a contact person, if there were any costs involved. And we created a resource that the CHWs could use to assist them in referring participants. The participant manual, we took a manual that had been used in a research tested study, and the manual included 4 sessions. The first 2 had 4 modules. The first 2 had multiple sessions. The healthy eating one, if you look at that, you will probably note that we were following a Mediterranean style diet. Then the physical activity also has 4 sessions, and then 1 session each for taking medications and quitting smoking. And the quitting smoking was largely oriented towards referral to a quit line. So we adapted the manual for rural Eastern North Carolina, and I'm not going to go into all of the adaptations here. We highlighted food that was commonly eaten. We changed brands and photographs to those preferred locally. So Hellman's was changed to Duke mayonnaise, and in Southern Mediterranean diet, mayonnaise is a healthy fat. Most importantly, we greatly reduced and simplified the text in the manual. And we also added photos that were representative of the community and community priorities, including photos of younger Black men walking and lifting weights. So aim 2 was to test the impact of these strategies, and we tested impact on both implementation and effectiveness outcomes. And this type of study is called an effectiveness implementation hybrid trial design. In this case, it's called a type 3 hybrid trial because the primary focus is on the implementation outcomes, and we are confirming our ability to achieve the same effectiveness outcomes or similar to what has been achieved in prior studies. So this is our evaluation framework. You see our implementation strategies listed there. Implementation outcomes included reach, acceptability, and fidelity, and then we did measure effectiveness outcomes, and those were dietary intake, physical activity, and weight. So we achieved good reach. We reached 386 participated in the intervention, which represented slightly more than 30% of those who were invited to participate. Of those, 340 were retained to the end of the intervention, so that's an 88% retention rate. And another thing that reach looks at is whether or not those who you reached were either representative of the wider population or overrepresent those at greatest risk, in this case, at greatest risk of cardiovascular disease. So you'll see that 88% of our participants were African American, and 75% were female. Now, that may seem like 25% is a low number of men, but that's actually very good to get that many men in a study like this. Intervention fidelity, we're still working on some of the analysis here, but generally the CHWs delivered content, assisted participants in setting goals, followed up on goals, and made referrals as intended with fidelity. However, participants only completed 40% of the referrals, so that's an area for further work. And this just shows you that the CHWs completed the majority of the in-person one-on-one visits and phone calls per protocol. Effectiveness outcomes, we saw significant pre-post increases in fruit and vegetable intake, decreases in sugar-sweetened beverages, and an increase in nuts, which is another goal of the Mediterranean diet. We saw an increase in moderate intensity physical activity, and most participants lost a small amount of weight. And then our final aim, we packaged all of this intervention into a toolkit that we now make available to others who may want to replicate our intervention. All right, the study we are just embarking on is one to scale up the heart health, which we now call the Med-South for Mediterranean Southern Lifestyle Intervention. The purpose of this study is we have an effective lifestyle change intervention. We have identified the implementation strategies needed to implement the intervention in rural health departments and federally qualified health centers. We now need to identify the implementation strategies needed to scale up the intervention across multiple health departments and federally qualified health centers. So the approach we used for the past 5 years, where we did a really closely engaged partnership with the communities, was a great approach to deeply understand what it takes to implement this intervention within federally qualified health centers and health departments. However, that model would be very difficult to scale across multiple federally qualified health centers and health departments. So in this study, we're moving back from that really close engaged approach and exploring new strategies that we can use more widely. So our current study aims look similar to those of our prior study. We're engaging partners to develop and refine implementation strategies for scale up in our first year and a half. And so we're partnering with 2 FQHCs and 2 health departments. In this time, however, we're partnering with them to design and pilot test scale up strategies, and I'll talk more about that. Then in aim 2, we're going to compare the impact of 2 formats for delivering those implementation or scale-up strategies in 20 settings, and then we're going to disseminate, again, the intervention and implementation strategies. So this is our current study evaluation framework. And so you see at the bottom what FQHCs and health departments need to do to integrate this into practice, the implementation strategies that they need to use. And so those are largely the implementation strategies that we developed over the past 5 years, to which we have added the request that they create implementation teams and designate site champions. At the top of the implementation strategy box, you see what we are going to do to scale up the intervention across multiple settings. We at the Center for Health Promotion Disease Prevention. We're going to create a learning collaborative where we'll bring representatives from different sites together. We're going to provide training. We're going to provide technical assistance, audit and feedback, and provide an implementation toolkit. We will then measure implementation outcomes and effectiveness outcomes. So we will be using an effectiveness implementation hybrid 3 design. In this case, this will involve site randomization to scale up format for 20 sites. So we're going to do our scale up strategies in 2 different formats. We're going to have a distance arm where it's a virtual learning collaborative with online trainings. And then an in-person arm where we bring representatives from the FQHCs and health departments together for an in-person collaborative. So what we're trying to assess here are the trade-offs between the ease and feasibility of doing things in a distance format of the distance arm, and then the loss of that interpersonal connection that's possible through the in-person arm. So I will, as a qualifier, say we may or may not be doing the in-person arm after all, given the COVID, and may need to shift to a full distance arm, but we are currently in the process of exploring that with our partners. So that is the end of my presentation. What questions do folks have?
Great, thank you, Dr. Leeman. So as she just said, we have some time for some questions. Just a reminder, you can type them in the chat box. That's probably going to be easier than people trying to talk. We do have a couple questions that were sent in before that we can start with, so that way we can give some time for everybody to write their questions if they have any. So I'm going to start with one of those. The first one is, does implementation science apply only after I've established my intervention's effectiveness?
No, and more people are thinking about implementation as they're designing their interventions. So designing their interventions with implementation in mind.
Great.
So the earlier, the better.
So it looks like we have a couple questions coming in. So one of them is, how soon in intervention piloting and testing do you start thinking about how to scale up? Currently still piloting through an RCT, was in parentheses.
Okay, great question. So I definitely think that starting to think about who you're going to partner with for scale up is a great thing to start doing early in the process. It takes a long time. You have to have I can't say enough about the importance of relationships to implementation science and trust. And so starting to build those relationships and trusts early on. And then you also can get a sense of what kind of scale-up strategies is your partner most comfortable with. And you can start learning about the scale-up strategies they're already using as key guidance to the kind of strategies you might develop down the road when you have an effective intervention that's ready for scale-up.
Okay, and it looks like another question is, what resources are available at UNC in terms of expertise in this area?
Great question. We have, the TRACS has a dissemination and implementation methods unit, and you can request a consult from that unit through the TRACS website. So that's probably the first place I would go. There's also the Odom Institute has a training on the use of implementation of qualitative methods in implementation science. The School of Public Health has a course, graduate course in implementation science that I would recommend that you go to. So those are, and also the TRACS has a website called the Implementation Science Exchange that is a great resource of additional information on implementation science, and has copies of example-funded implementation science studies.
So if I'm interested in de-implementation, what models or frameworks would you recommend? CFIR still applies?
So that's a great question. And the field is still exploring how de-implementation is different from implementation, and it is likely that there are differences between the two. And there is a de-adoption framework out there, and there is literature on de-implementation out there. I'm currently conducting a de-implementation project with Katrina Donahue and Laura Young, and we are using models very similar to others used in implementation science. In that we identify barriers and facilitators to de-implementation, and then we drew on Powell's list of implementation strategies to identify the implementation strategies that would target those barriers and facilitators, and are now assessing the effectiveness. So you can use the same frameworks, but there are clearly differences that are still being pieced out.
So it looks like a follow-up question for that one is, could you define de-implementation?
Okay, great. In this, I'll tell you just a little bit about the study we're doing. There are a lot of low value practices that are being used, and those low value practices take resources, time, energy away from higher value practices. So this is a real priority for the field, is to clear folks' resources and attention away from what really isn't adding value. And in our case, it's self-monitoring of blood glucose for type 2 diabetes patients who are not on insulin. And Katrina and Laura did a study where they demonstrated that there was no clinical benefit to self-monitoring of blood glucose in that population, that quarterly A1C tests were sufficient. And so now they're working to de-implement. Get providers and providers to have conversations with their patients, recommending that they stop self-monitoring of blood glucose. Other questions?
Okay, so it looks like another one just starts off with, thank you for this talk, Jennifer. Can you give any pearls on how you have navigated what can be a tension between intervention fidelity and feasibility of implementation? In other words, if implementing sites aren't able to carry out the intervention as originally planned, what is a reasonable approach?
Oh. So doing the, you have to be really careful. So fidelity is another area that's gotten a lot of controversy lately. And I think that a lot of times, and the standard approach is you identify the intervention's core elements, and there is also a modifiable periphery that you can change as long as you stay true to the core elements. And core elements may include things like dose. And really, you don't want to there is a problem with moving back on dose and moving back on some of those core elements at the practice setting level. But that model largely applies to packaged intervention programs. And a lot of times what you're implementing is not that prescriptive and that defined. So when you're doing like practice guidelines, or there is more flexibility to adapt them to the resources that are available in the practice setting. So that was kind of a jumbled answer. I think making sure you do the work up front to make sure you're selecting an intervention that is feasible within the practice setting is the first. However, situations can change for the practice setting, and then figuring out, is there a way to adapt the modifiable periphery of the intervention while retaining the core elements? If not, do you need to switch to another intervention?
And we have another one. Are there certain institutes at NIH that focus on implementation, or are all institutes funding this type of work? In other words, what are some good strategies for obtaining funding for projects that include implementation?
So I would look at the dissemination and implementation research in health PIAR out of NIH, which includes a list of the institutes that fund through that funding announcement, to figure out which institutes, many do at this point, fund dissemination and implementation research. The CDC has also been a generous funder of this kind of research, although their calls are more limited generally.
And what are your...
Actually, I just want to say, I should say, I'm on a PCORI funded DNI. PCORI funds dissemination and implementation research. Also, there's limitations around that. I'm also on an ARC funded study that is looking, although ARC, also you have to pay attention to how each institute is framing this issue and how they're funding it.
What are your thoughts on the need or not for trademarking ideas if scale-up is desired? When should that be done and why?
So there are resources at UNC that can talk to you about that. And so with the Connect Home intervention, Mark has been in conversation with folks at UNC to make sure that his intellectual property is protected. So I don't have any expertise in that area at all, but I think it's a great thing to pay attention to and to be thinking about and getting the support consultation that you need.
Okay, it looks like I'm not seeing any more questions come through, so we're welcome to wrap up unless there's anything else you'd like to say, Dr. Leeman.
No.
Okay.
It's been a pleasure, and have a good day.
Well, thank you again for taking the time to talk to us. We're going to be sending a follow-up email to everyone in the coming days with a link to access this recording in case you would like to listen to it again or share it with your colleagues. Please join us again in a couple weeks on Wednesday, June 17th at 10:30 when our speaker will be Dr. Leena Sharma presenting Tackling Obstacles to Development of Strategies to Prevent Poor Outcomes in Knee Osteoarthritis. Thank you everyone again for attending this talk, and we look forward to seeing you again. Thanks everybody.
Bye.